also about the products we have been handling with the product. So all these details will be going with the.
So shall we start with the presentation, sir?
Yes, you can start. You can view.
So this session will include the types of staplers, how a tissue reacts with the staplers when we are talking about endomechanical portfolio of Ethicon. Going forward, this is the total sections of the contents which we will be taking care of with today's session, which involves a normal framework of why this content came into the picture, what is the technology involved, what are the human factors or tissue interactions, what happens with the during firing a stapler. So coming to the this framework, why we came into this is we also know we require an optimal clinical outcome for the patient, for the betterment of the patient's results, surgical results. So it doesn't require only the procedural management, it also requires the proper management of tissue along with the patient management. So in J&J, we in Ethicon Endosurgery or Ethicon, we always work onto the same thing, understanding the living tissue dynamics, so that with our devices, we help or we reduce trauma associated with the tissue with the tissues during handling. So when talking about the tissue management, it is minimizing the tissue trauma foundation of is our device. Overall, we have also patient management as well, patient support also. So which talks about we have brand called as Realize, which is for patient management solutions. Comes to the procedures, we are the best judge for the procedures basically when it comes to. So we are integrated within our system also, where we help or we try to incorporate systems where we help the surgeons to get trained in the latest procedures or latest techniques of the particular procedure. Components of tissue management mainly involves your three parts, basically tissue dynamics, technology, and human factors. Tissue dynamics is basically composition of both living tissue and also the device which you are using. Then technology wise, the stapler what you are using, that is main factor. And human and device interactions is basically like how you handle the device, how smoothly you are firing a stapler, how smoothly you are handling the staplers. And specifically reuse of the staplers also makes a big factor as a human factor, where the human device interactions also works out. So this is one of the innovative thing which is actually have started in coming to the surgeries. It started with open surgeries, then we had hand assisted surgeries with laparoscopy. Then we had a laparoscopic and microsurgeries which came with a high patient benefits. Now we are coming towards the single site laparoscopic surgery and the robotic surgeries, which has been always the surgical spectrum has shown very clearly that we are looking at a better patient clinical outcome. End of the day, we are looking at a better patient benefit. So factors, why this slide is again on the. So coming to the origins of the stapling, the first surgical stapler was actually introduced in the world was in year 1999, where Dr. Hammer Huttel from Hungary, he was an Hungarian scientist who actually introduced staplers. So during this period, now if what you see staplers today, you have pins loaded in the reloads prior to the firing. Earlier days, it was made of only steel, and every reload in every pin was supposed to be loaded by a single person. So there used to be a separate loading instructor for the same thing. For example, if you see this staplers in my hand in the video, if you see, just hold on. Okay. If you see the stapler in my hand, this is the preloaded one pins. So when Dr. Hammer Huttel came into the picture, he designed where actually you have to open up one pin, load it in this, then align it to the staplers, then you have to supposed to fire. So that was very cumbersome process basically. But down the line, everything became designed nicely. So during Second World War only we got the first staplers which had a preloaded cartridges. Further than by 1976, Thicon had already taken over this, and we came up with the current design of staplers, what you are seeing, the disposable ones. In case of surgical stapling, a primary objective of a stapler is basically to have a proper hemostasis and leak. And most of the times, the leakage or the hemorrhage which happens in any stapling anastomosis or in a resection is basically is secondary to a staple line failure. So it is just next to the staple line, and most process of this leaks happens usually within 2 days of post-op. In case it is ischemic, it will happen only after 5 to 7 days, which is commonly as such it is very rare. So that's why it is very important for us to understand how the stapler reacts or how the tissue reacts with the staplers, so that we can go ahead with the we can avoid as much as we can avoid stapling issues basically. So our living tissue has a normal without any compression. It is always a thicker tissue. When it is compressed with stapling device or any other device, there is a compression which is there. What stapler does it holds this compression and holds this energy stored as a in the stapler. So these are the different stapler available in the market. So we have linear cutters, which generally does a linear straight line resection or anastomosis. So it can be used for your side-to-side anastomosis and for the resection. We have curved cutters, which is popularly known as contour. Then we have circular staplers, exclusively designed for end-to-end anastomosis. Then we have linear staplers. So linear staplers, they only do the stapling. So if you have a stomy which you want to close it, so linear staplers are generally used. So all these staplers gives minimum 2 rows of stapling on either side of the cut line. In case of linear staplers, it is only staple line. Linear stapler is this one. In between, if anybody has any doubt or anything which you want me more clarity, please feel free to ask. You can put it in the chat box as well, so that we can take up that question, or if any concern is there, we can pick it up. I hope I'm not going too fast. So type of compressions in all these staplers are different. So first, linear, it is basically compression which is formed by the reload and the stapler. In case of circular staplers, it is circular, which is screw mechanism, which is there as a closing knob, we call it. So which helps in closing it. So this is what actually the compression looks like when we are using the circular linear staplers, curved cutters, or the circular staplers. So this gives you a circular impression, whereas here it will give you a linear impression. Here you'll have again linear impression. Curved cutters will give us still linear impression. It looks curved, but impression will be linear. Endoscopic, again, we have different staplers available in the market, but most of the staplers, they give compression, system-wide compression given is only by our staplers, which is echelon flex. The Covidin staplers has a compression which is a cam tube mechanism. This is basically like a crocodile mouth, which actually gives compression more at the proximal end of the opening rather than the distal end of it. But in case of echelon flex, it has a compression which is available in from tip to toe in case of this jaws. This is how it looks like in terms of compression. If you see here, this is our Ethicon's staplers, where it is compression is shown system wide starting from tip to toe. Whereas in case of Covidin, you can see here, there is an opening in the distal end of the stapler. So this gives you not a full compression to the tissue, basically, proper compression. Why optimal compression is important is basically to avoid any kind of staple leak. Optimal compression not only gives you a better staple formation, but also it gives you a better hemostasis as well. Optimal compression will give us secure anastomosis because it doesn't cause any kind of tissue tension or any kind of tissue condition. It is there, tissue thickness or anything. It takes care of every aspect of the tissue dynamics. In further slides, you'll see what are the different tissue dynamics which actually affects the overall performance of a stapler. So optimal compression is very important in case of having a proper staple line. This is just a basic of stapling where when staple is in open condition. So this is what is called as leg. Then we have a crown. A staple, once it is fired, it forms a B shape. You can see the B shape here. So in a stapler, basically there are four parts. First is the cap, which is also known as stapler thinner. Then we have the staples, followed by staple drivers, which actually helps the staplers to push forward and staple the staple line, followed by the cartridge body. This is one of the key differentiator between the staplers. Most of the staplers which is made are made up of inert material titanium. This is a regular or consistent atomic structure of titanium. On the right hand side, what you're seeing is your deformed atomic structure when you have applied force to it. That is, so if you say talk about the staplers, so this is in the open shape condition. This is in the closed staple formation. The issue with the titanium, pure titanium, is it is very soft in nature. It requires less force to bend or also less force to open up as well or to reform to the same structure. So if you
Hello, Harish, are you able to hear me?
There is some network connection problem at his end.
Okay.
Can somebody call him and check?
I'll just call him and ask.
Thank you. Yeah, he's back. Please unmute yourself.
sorry, sir. Actually, I just
No problem.
had a disconnect.
No problem.
Internet issue. So I think we had we was talking about the titanium material, basically staple material. So shall we go ahead?
Yes.
Yeah. So initial design of staplers were with the titanium material, but coming forward, we had titanium alloys. So the plus point of titanium alloys is the force to fire is definitely higher, but force to come back or to reform or to deform to original position is less. So you have a higher spring back option and force to fire is a little higher. So titanium alloy as such gives you more strength. It gives you more strength for the tissue to hold. So this is the overall types of staplers which is available in the market, which gives you a very tissue thickness. So we have available with gray, white, blue, gold, green. This is basically a color coding for the closed staple height. So when we are using mainly for vascular reloads or vascular structures like any vessels, we generally recommend for white or gray to be used based on the tissue thickness or the vessel thickness. So white gives you a closed staple height of 1 mm, whereas gray gives you a closed staple height of 0.75 mm. Blue gives you 1.5 mm of closed staple height, gold with a 1.8, and green going forward gives you 2 mm of closed staple height. The plus point of understanding this, the way to understand this is, which I feel as a very, make it very comfortable is G for green, G for gaster, blue for gold, blue for B for blue, B for bowl. So it makes it very comfortable for to understanding. Okay, this is what we are supposed to use in case of using it in the bowl, blue, using in the stomach, green. So otherwise, to make it as a layman language, thicker tissues, green, thinner tissues, blue, if it is intermediate, because you'll be seeing patients with CA who are radiated. So their tissue thickness may vary. So you can use an intermediate tissue thickness as well, which is gold. Other additional things which is considered in case of stapling is buttressing material, which was seen earlier to be used very quite frequently. But now after seeing the overall papers and other things, they have seen that there is no major difference when you're using a buttressing material. It doesn't help in any cases of leakage. So whether it is case of gastrointestinal tract or in a case of even pulmonary cases where they're using for the bronchus, it has been seen there is no any specific benefit out of it. So if you see most of the surgeons who were actually using buttressing materials, they have stopped using now. Even the papers or clinical papers also says shows us the same results. Coming to the most important factor of the tissue device instruction is tissue dynamics. Sir William Halsted, who was one of the pioneer when he came to the anastomotic principles, he has very clearly mentioned that in case of having a very good anastomosis, there should be no tissue tension. It should be a leak-proof anastomosis, which is the key of any anastomosis. Good hemostasis should be there, adequate blood supply and adequate lumen so that your peristalsis is not affected. Coming to the tissue characteristics, if you see there are tissues are not as a single character. It is different in nature. When we talk about biphasic nature, it has solid components also, which is the tissue. It has a liquid content also, which is the water and other liquid contents which is in the body. Second, when you say about viscoelasticity, we also know that it is viscous in nature when you handle it. And in fact, elasticity of tissues are different in different locations. For example, if you talk about jejunum or ileum, it will have a better elasticity compared to a rectum or to liver, as I say example. Hysteresis wise, so when we say hysteresis is, but nothing is how frequently it comes back to the original position. So if you do a compression and you leave it, it will come back to its original position. That is what is called as hysteresis. For example, you take a sponge, if you hold the sponge for 10 minutes and leave it, it will come back to its original position. So that is what is hysteresis. Tissue creep is, I think, but it moves as per the, when you compress it, it stays on the same position. So this different phases of the nature, we need to use a staplers in a very good way so that we don't land up with any of the issues which Sir William Halsted has mentioned to avoid any leak. So this is one very important thing, the reactions of different materials under pressure. So if we apply pressure to steel, there is whatever force you apply, whatever compression is steel is having, it is not going to reduce it at all. Coming to rubber, we apply more force, it actually compresses, but it again retains back its original position. Tissue, if the more you force apply, there is a compression, but this compression stays at the same level. It stays at the same level, but after 15 seconds, it reduces down another 15 mm. So if you say here 0.5 mm, so if you see here, tissue was compressed, the first arch you see, it is the tissue when force was applied. And over time, if you see, within 15 seconds, there is a drop in the tissue thickness, which is quite equal to 0.5 mm. What impression it gives is, with the compression and time, we get a better staple line. So if you see the red box here, it is without waiting for the compression. After compression, you're just directly firing. You're not waiting for 15 seconds. The high possibilities are staple line will be not proper B. But if you see the green box here, you can see once you have waited for your 15 seconds to allow the tissue to settle down. So because when you apply the force to it, tissue, the liquid parts evaluates outside and it forms as a compressed tissue. So the staple line formed here is much better compared to the pre-compression firing. There's just a comparison studies between the different this thing. So if you see here, when you have given a compression, the with time, what is the difference? What it gives you a compression is till 5 seconds 0.35. It's just an average. In 10 seconds it gives you 0.4. In 15 seconds it gives you 0.5 mm of closed staple compression, additional compression for the tissue. But after 15 seconds it stays at the same line, so there is no additional compression. So you wait for 1 minute, 5 minutes after the applying the stapler. It doesn't make sense, because within 15 seconds, whatever additional compression you are supposed to get with time, you will get it within 15 seconds. After 15 seconds, you don't require to wait for additional time. Additional tissue compression statistics which is supposed to be considered is what is the safe thickness reduction, which is approximately 25%. Every tissue has different burst pressures, like intestines have lesser burst pressure compared to stomach. Occlusion pressures also has to be considered, because vascular structures have more occlusion pressure compared to the other lumens. So the sealing capacity is better in case of other structures compared to the vessels. This is also one interesting study which was given by our most of the bariatric surgeons. They consider this as a landmark study, where they have seen that there is a very tissue thickness within an organ. So when talk about the stomach, if you go with the lesser curvature towards the greater curvature, the lesser curvature are more thicker tissues compared to the greater curvature. In fact, if you go to proximal to distal, fundus is thinner than pyloric antrum. So there is a varied tissue thickness within organ as well. So these things has to be considered well firing. So suppose if we are using here, just want to pop out one question to the team, to the listeners. So if we are using it that a fundus any stapler, what should be the staple which we should use? It should be blue or green? Hello? Anybody can respond to this? And if you're using to the antrum, what would be the color, blue or green? So when we are using towards the fundus, it should be blue. When you are using towards the antrum, it is green. The human factors. The human factors involves your both intraoperative as well as preoperative and postoperative conditions. So preoperative, what is the surgeon training when we talk about like is he comfortable while using the staplers? Patient comorbid conditions affects a lot to the overall effect of the staplers, the way it affects into the total surgical procedures. Like if patient is it is radiated or chemo patient, the vascularity of the tissues are higher compared to normal. Intraoperative or anastomotic is like they follows basically the William Halsted principles. which is adequate lumen blood supply and good hemostasis with leak-proof anastomosis and no tension. Post-operative, there is basically whatever you antibiotics, inflammatory response, and healing and pain control. This all affects the overall response to the stapling. So that's it from the staple point of view. Any other questions to be required to be? I can take over the questions right now.
Hello,
Yes, sir.
Harish?
Huh, sir.
Yeah. Okay. So if there are some questions, you can ask them.
Sir, I'm looking at if somebody has any questions, I can answer it right now, sir. Or if anybody is looking at hello, any queries they have, I can take up, sir, now. Or I'll just show up some staplers here, sir.
Yeah, I think that is better. You can show some staplers.
I hope my video is visible. So when talk about the stapler, there are basically three components in a stapler. One is the cartridge, which is the reload we call it, or a cartridge you can call it. Then we have the stapler's two arms when it comes to the linear cutter. One is called as cartridge half, where we put the reload, where we put the staplers basically. Then we have the second half, which is called as anvil half. So we have stapler, if I hope I'm able to show there very clearly. So this is the place where actually the stapler goes in and forms the B shape. These are called as anvil grooves. Now coming to the stapler loading and uploading, which is very important. Every stapler will come with a cap. Here we don't have a cap here right now because I'm using a used reload. Now coming to this, when you are loading it, it has to be remembered there are different grooves in it. So if you see here, you have a groove here. This groove is supposed to get fixed in the cartridge half of in this position. So how to load is align the two ends together in this way and drop it into the stapler. You'll get a click sound. I hope that click sound was audible. You have a firing trigger, which is closing trigger, which is kept here. It should be always open when you are loading the cartridge. After loading of the cartridge, you have the anvil half, the other half. So while aligning the two ends, most of the times what happens is surgeons generally try to align it in between the handle here. Okay, so what happens is while aligning like this, you require time. What happens is sometimes you'll try to align it in the center so that it works out very nicely, comfortably. The easiest way to handle or to align the two ends is if you align it at the proximal end like this and drop it, it will come back automatically at the closing. And after that, your closing trigger, close it, and you have a firing handle. You can just go ahead with the firing knob. This is a firing knob. I hope it's visible. Firing knob. You have to use it and fire it in a one stroke till the end. Then you have to come back to the original position. For opening again, we have grooves available here. So you have to just pull it down. It will open up. After that, again, you can see some grooves here, which is based on the color of the cartridge. Hold it from both the ends and pull it and discard the used reload. That's the way we are generally asked to use the linear cutters So we have two range of linear cutters. One is NTLC and one is TLC. So the one which I showed is TLC. This will give you a 2 rows of staplers. We have another staplers which is called as NTLC, which will give you a 3 rows of stapling, and you don't have to bother about the stapler, what color of the cartridge you have to, because there is an option for selecting the cartridge. In the, just a second, I'll just show you the product. So this is what is the NTLC basically. So plus point of NTLC is this comes with a very good design of 6 rows of stapling in open stapling. This is the one and only product in the market. This gives you 3 rows on either side of the cut lines. It gives you an additional row every stapler. And plus point is you don't have to bother about the blue reload or green reload to be selected. Before firing, you can take a decision that you want to adjust it to blue, gold, or green. So based on the tissue thickness, on the OT table, you can decide which color you want. So you don't have to bother about the color selection here. Then coming to the other types of staplers, we have the circular stapler. Circular stapler, where basically for your end-to-end anastomosis. So we have the two ends in circular staplers. So we have the rotating knob. You can see here, this is a rotating knob. We open up the anvil here. This is anvil. The circular ring is the anvil. So this goes into the proximal end of the lumen when you have done the resection basically. So this will go into the proximal end of the lumen. You will put up the tissue over it and do a purse string and hold it tightly. So while doing purse string, you have to be careful that there is a notch here. You can see this notch. This notch should not get pierced or should not get submerged in the tissue. So it should be, the purse string should be below this. So you'll just apply the purse string and keep it in the proximal end like this, and you'll go trans-anally. If you're doing a low anterior resection case, you'll go trans-anally with this closed end of the circular stapler, then push it inside, and you'll come up to the rectal stem. You'll open it up at the rectal stem. You have the rotating knob. You'll open up. Opening is basically clockwise direction. You'll keep it opening. You'll open it up. So your trocar, there is a sharp trocar which will open up from the rectal stump, and you'll get an orange line. You can see here orange line. This orange line should be outside the rectal stump. Once it is out, the other end, which is the proximal end, which we have the anvil, will club the two ends. You will again get a click sound here. Then we'll approximate the two ends. So after approximating, the two ends will come together. Then we'll have a tissue compression scale, which is available here. You can see here. So the tissue compression scale gives you a range of stapling height, basically 1 to 2.2, basically, so that whatever the tissue thickness is, you can accommodate the tissue easily in this stapler length. So once you are closing, you'll have a feel of a hand tightening. So once you have a hand tightening, it may be anywhere between this green range, which is a tissue compression scale. So once it has reached, you have a safety lock. You have to remove the safety lock. And for firing, you have to, with the complete force, you'll fire it in one go. Plastic to plastic. So plastic to plastic means this is what it should be. Plastic to plastic. Once it is plastic to plastic, open it up, push back the safety lock back to the position, because it has only one time firing. So in case accidentally you fire it, you may have a leak in the anastomosis. So only single time. Then open it up slowly with a 2 twists. 2 complete round is required here. Once it is done, the vacuum which is created because of the anastomosis, which is released, then you can just fishtail it and take it up. You can inspect the donuts in the anvil and the gun to have a safe anastomosis. Thirdly, in this staplers, I showed you basically that this is what the tissue range is, green color. So for example, this is what if you can see, observe clearly here, you can see here this is the staple length. So straight is the leg. These are the crowns in the top. So if you close it, it will start forming B. You can see it has formed B. So this is actually in the tissue compression scale length. So if you close it fully also, it is till the end. It is still forming a B. If you are putting it two in between, it is still forming a B. So the impression is basically with circular staplers, which we give is whatever the tissue thickness is, we take care of every tissue thickness because of its longest staple length. So that's a plus point. Then coming to the staplers, most important staplers in current scenario is a powered staplers, which we are using for your laparoscopic procedures. Length of this is little bigger, so I'm not able to show it properly maybe. So this is what it comes out. In case of linear cutters, you see you have a loading technique which is outside you are doing it. Here it is totally different. So here again it has also the same parts. If you talk about the distal end from the proximal end of the gun, so we have the anvil half, we have the cartridge half, we have two ends. This is black color. What you're seeing here is an articulating joint. So this is basically used to articulate in case of you require any articulation during the firing. So you can see here the articulation which is there. Okay, so this can be used for your firing anytime, like whatever angle you require to fire. Thirdly, the shaft length. Then we have this articulating fins. This fins helps in rotation in 360 degree. Also, when you pull this fins towards yourself, the articulating joint becomes free and gives you a place whichever way you want to rotate in either side. So once you want to position it at one place, for example, like this, you have to release the articulating fins. Then we have a closing trigger. Then we have a safety lock in this. You can see a green color safety lock, a red color safety lock here. Then we have a firing trigger, which is a gray color. And onto your this is, you can see the release button. So you have to open it up. So this is for closing trigger. This is for release button. And for in case of misfire or in case of any troubleshooting, we have a reverse button as well as in this. So this is powered platform. So how to load or reload in this? So this is how the reload is supposed to come to you, which is basically with the cap and stapler is full. So once you comes to loading is, you have to slide it down at an angle of 30 degrees till the end of the stapler half or the reload half. Push it and done. So you'll have a click sound again. After that, you remove the safety cap for firing. To just close the handle here, remove the safety lock, and fire. So this will give you a firing stroke with a powered button. So once the battery is loaded, it will fire. Once firing is done, it automatically it comes with the firing motor sound. You will get it, which will give you an indication that your firing sequence is completed. Once the firing sequence is completed, how to remove the reload is very important. If you can see, the color of the reload is black here. So you'll just hold your thumb onto this color and your 4 fingers onto the anvil and push the cartridge. It will open up. So this is all about the staplers from my end, sir. Anything which you want to add up, we can add up furthermore onto this basically.
Hello.
Yes, sir.
If there are bowel or edematous, and whenever some pathological condition,
Yes, sir.
how about because after 2 to 3 days edema comes down, the staples may become loose.
So basically, sir, what happens is there is that when we talk about the uses of staplers, we talk onto the benefits of the staplers based on the what tissue dynamics are also currently. So we also spoke about the pre-operative condition and post-operative condition. So pre-operatively, if patient is already having ischemia or having issues with the bowel thickness or tissue, it is advised not to use staplers for that cases. because there is high risk of staple leakage basically in that patients. Only thing is, if we have taken enough margins from the ischemic tissue, then definitely stapler will hold on. But advised is to keep it open and observe it.
In sometimes in esophageal anastomosis,
Yes, sir.
actually they use staples.
Yes, sir.
Site of anastomosis. Yes. Just a minute, 1 second.
Yes, sir.
Yeah. Harish,
Huh, sir.
one or two patients after esophageal anastomosis, no, at
Yes, sir.
the site of anastomosis, they always complain that there is some form of holding. Is it common with the stapled anastomosis?
Yes, holding of the food you're saying at the anastomosis, right, sir? Near the neck, the esophageal gastrojejunostomy. So basically what happens, sir, the esophageal when we do, we use staplers. Generally, we use the linear cutters. So advised is basically in cases of esophageal at the neck, they suggest us to use a end-to-end staplers. So you'll not have that kind of food is getting holded in the neck basically, because generally what happens, staplers over the time the tissue covers the staplers. So staplers doesn't cause any kind of tissue holding basically.
Yeah.
The food holding basically, food holding. But otherwise, it is recommended to use more in this kind of cases. They recommend to use end-to-end staplers rather than using a or doing a side-to-side anastomosis, I would say, sir.
And
As far as my understanding, basically.
Yeah. Understood. Got the point.
Yes, sir. You're saying something else, sir?
Yeah, in gastrojejunostomy,
Sir.
linear different types of staplers with side-to-side anastomosis.
Yes, sir.
Anything you want to highlight on those staplers?
So we have a different linear cutters available in the market, sir, which gives you varied tissue thickness. So again, when you're doing a gastrojejunostomy, very important is to understand is what is the tissue thickness, what we are getting from the stomach end. So for example, we are doing a total subtotal gastrectomy where antrum, part of antrum or part of duodenum has been resected out, and we are doing anastomosis to the body. We are doing jejunum anastomosis to the body of the stomach. So in this case, stomach thickness is relatively intermediate, and the small bowel tissue thickness is slightly lower. So we should use a product which should give us a both comparatively. So when you're applying the staplers, seeing the tissue thickness, it is recommended to use either blue or green. But again, depends on the tissue thickness. If it is radiated tissue or it is having some other comorbid condition with the patient, then we have to take a call, and then based on that only, we should take a call we should use blue or we should use green. Or in case still you have a doubt of blue or green, you can always go with the gold, which gives you an intermediate tissue thickness. So like blue gives you a 1.5 mm of close staple height, whereas green gives you a 2 mm of close staple height. But gold will give you a 1.8 mm of close staple height.
Thank you. Prem, you would like to ask anything? Can comment after.
That's not it.
Thank you, Harish. Thank you.
So thank you for your time, sir.
Yeah, you can please continue if there is any other things.
So stapler wise, almost done with the staplers. If anybody has any particular question with respect to staplers, we can take it now, or anybody can reach me offline as well. I'll drop my number and details in the chat box.
Do you have an advanced stapler there?
Sir, right now I'm not having, sir, actually.
Okay. So can you please show once again that linear stapler loading?
Yes, sir.
That will be
Yes,
very
sir.
good because regularly we use this. Yeah.
Done, sir. And I'll just do it, sir. So when it comes to Advant and this thing, there is only two differences majorly. The main difference is the Advant is reusable gun, and the one which I am showing now is a purely disposable ones. Though we in India they reuse it basically. So this is called as TLC, and the other one which we are using in KLE is Advant. So loading and unloading is same. There is no major difference. Loading of the reload, it has the same design. So I'll just show it again. So if you see here, we have the grooves here present in the, you can see the design here. Okay, here both the sides the same design is there. In case of Advanced gun also we'll have the same thing in the reload, and in the gun also we'll have the similar design in the Advanced gun. So when we apply, just keep it in this angle into the cartridge and drop it down. During this time completely, your handle should be open. This is a firing handle, closing handle. This should be always open. During this time, it should be open. So when you're applying it to the tissue, align it, the proximal end, drop it, then close the handle. For firing, again, firing handle, firing knob, use palm to fire it because we use titanium alloy. So force to fire for titanium alloys is always higher, which I showed you the molecular structure of it. So for this firing, you have to always have a more force to fire. So always use a palm. Don't use the thumb, because if you use thumb, you'll have more of power required for firing, and because of which you'll feel pain in the thumb. So always use the palm fully. Then fire it. Once firing is done, come back to the original position. It is always mentioned in the gun. Turn back the knob here, firing knob here. So just come back to the firing knob and open up, remove the cartridge, and ready for the next firing. One thing which I missed it out earlier was after every firing, anvil and the gun, both the things should be cleaned of the used stapler pins or the fired pins which is not utilized in the patient, so that whatever unused pins are there which is lying in the gun, or the tissue or debris which is lying in the gun should be cleaned off, so that next firing is more smoother and safer. Because sometimes the unused pins which is lying still in the gun can lead to issues basically with firing.
Harish, do you have a mannequins there so that you can load these as in a bowel so that it will come till the end of your cartridge, so that there should not be space left behind, so that the cartridge will go waste. Why? Because the tissue should be properly placed in between the two blades. Am I right?
Yes, sir. Just give me a couple of seconds, sir. I'll just have. I have.
See, because why I'm asking this, because most of the times we do have this problem. Unless until we get an assistant who knows about the loading and unloading about the staplers, it becomes a difficult task for us. Or again, we'll have to clean our gloves and we have to go and load it.
I understand that, sir. Just a second, sir. I'll just. I got the.
You must be having tubes, no?
Plastic yeah, tubes is there, sir. Yeah, it is there, sir.
Just load it in that stapler and show it till what end the tissue should be there, so that it can cover the whole length of a cartridge.
So one important factor which is very important to understand for everybody is, sir, if you see here in the staple, this is a 75 mm length stapler. So the clean line what you're seeing here is basically your cut line. So knife will pass on through this.
Yeah.
So if you observe it clearly, there is a staple which is beyond the cut line.
Yeah.
So always this is one thing which should be kept in the mind. So I'm just loading it again.
Yeah. Yeah, that click sound should come. Then only you see that it is fitting properly.
Yeah. Yes. Correct, sir. So as you rightly mentioned now, if you see here, I am applying it. So in the proximal end, the tissue should be like this.
Yeah. It should come till the.
So if you are suppose you are doing a side to side anastomosis, it should be till the end. So if here what happened is, so in the cartridge half, so if in the cartridge half, if you go and see, sir, you have markings also available here.
Yeah.
So this will give you a very clear indication if a staple line is starting from here. You can see an arrow mark here.
Yeah. Yeah.
And there is another arrow mark which is showing here. So this 2 arrow marks shows you this staple line is there. So this arrow marks is exclusive for only for staple. So you can see here there is an end mark for the staples.
That is a distal end. This is proximal end.
This is what the staple line will be. So now this is basically when you're doing a side to side anastomosis, you can always insert as much as you can the length you are looking at. Generally 2.5 to 3 centimeters are considered good basically for any anastomosis. So in that regard, it will be good enough. But if you are doing for the resection angle, what you are asking, sir.
Yeah.
Now here, what I have done is I just folded the tissue so that I can accommodate it in the gun. Now if you see here, tissue is well within the gun. Right, sir? It is well within the gun. What is happening is there is a staple. It is within the staple line. It is saying it is within the staple line. But what will happen is it will creep a bit. Tissue creeps out a bit. So when you are firing, tissue doesn't hold it at the same level. When you are talking about like its viscoelastic nature, because of its viscoelastic nature, even after waiting for 15 seconds with pre-compression and other things, when you fire it, it will creep out a bit. So because of that creeping out, you will have a little bit space even after the firing. So that will be close to 1 mm or 2 mm max. So that tissue creep is there with the open staplers as well. But when you're using, there are 3 versions of staplers, sir. We have like Advanced, which is a reusable version. The one which I am handling it is called as TLC. Then we have NTLC. So if you're using NTLC, this tissue creep reduces down like anything, which is we call it as tissue slippage or milking out of the tissue. This reduces down as you use the more advanced guns, basically. So here I'll just show it once. If we fire it, this one with this condition. So this is actually an empty reload. I'm firing at one go. It will show us only the cut line, sir, because there is no staples in it. So come back to the original position. So if you see here, we have only the cut line here. We don't have staples in this, because of which it is showing only the cut line.
In the center.
So this is what the point. Yeah.
Yeah.
You can see only the cut line. So this. So you can see here.
What I mean to say.
So this is a difference.
No, what I mean to say was there has to be a tissue beyond your staple line. Then only hold tissue. Otherwise, it should not happen that the staple line should be covering the tissues. So then only we'll have the adequate length of anatomy.
True, sir. Very true, sir.
Harish, is it always recommended to reinforce the staple suture line with the sutures or some form of glues? What is the suggestion?
Sir, it again depends on to the position of the staple line. Like for example, it is actually not recommended to burying the staple line, basically what we call it, burying the staple line with the suture. So it is not recommended as such overall, but as for the company standards I'm saying, sir, there are certain clinical papers which says in certain procedures, like for example, suppose you are doing a total gastrectomy, you are doing a duodenal stumping. So the high chances of leakage are high, is very high in duodenal stumping, or rectal stumping, or bronchial stumping in case you are doing a lung resection. So there many surgeons prefer to use a additional suture line so that you can prevent any kind of leakage happening. So the reason behind is basically, as we know, these are the critical areas where the force or the flow of the fluids are high, and there is high chances, high pressure joints basically. So there are high chances of leakage. So what I suggest is, instead of using a stapler which has only 2 rows of stapling, you can use 3 rows of stapling. So this will not only save your time, but also give you a peace of mind also that, okay, you have additional row of stapling, which will take care of not only the leakage, but also give you a better anastomosis or better hemostasis. Sorry.
Thank you.
Okay, Harish, is the next person is ready? Harish?
Yes, sir, it is ready, sir.
Thanks for explanation. Nice explanation it was.
Sir. Thank you, sir.
Okay, thank you.
Back to the current.
So can we take a break for 5 minutes, sir?
Yeah, sure.
Okay.
Sure.
Okay.
Yeah.
We'll come back after 5 minutes.
Okay.
After 2 minutes, huh?
Sir,
ये कॉल नहीं किया था, मैसेज आया उसको, भेजा था, लिंक भेजा ना तेरे को यूट्यूब का।
मम्मा का फ्लैश इसको ऐसे निकाल देखिए ऐसे इसको ऐसे कर
हेलो हाँ सर हरीश है सर हाँ सर माराथली ब्रांच हाँ सर रेडी सर हाँ सर रेडी सर हाँ सर व्हाट इज द इशू सर एक्चुअली instrument not found okay okay sir can I come down today afternoon? I'll try to come down. Okay, otherwise Monday I will come down sir. Mm-hmm. No, I'll be there. I'll try to come today itself so that we can sort it out today. Actually, I have to go to Jayanagar also. So once I finish Jayanagar, I'll come there, sir. Huh, sir, I know. Apollo Cradle, Marathali, I know, sir. Okay. Thanks. Yeah, I will confirm you, sir. Give me some time. Maybe by 12 o'clock, I'll confirm you. Hello. 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 Huh, sir.
Hello, Mr. Harish. Mr. Harish from Ethicon, can you hear me?
At what time we will resume?
Sir, I'm here, sir. We can start now.
Mr. Harish from Ethicon.
Yes, sir. I'm here, sir. We can start now.
We'll go ahead with the further presentation.
Yes, sir.
Thank you. Take over, please.
Yeah, thank you. So now this session we will be going ahead with mainly with the stabling. We have finished tissue dynamics. Now we'll be going with the science of energy. So when we say science of energy, how the energy modalities which we are using in the current scenario, which affects our performance in the surgery. That is the whole idea basically. So when it comes to science of energy overall, this is science of energy. We have total 4 chapters which we talk about. So it is basically an introduction which talks about what are the principles of sealing or what are the physics of electricity which is used in our day-to-day surgery. Followed by what is a monopolar technology, how is the bipolar, and how the ultrasonic or advanced ultrasonic energy systems works. So this chapter will have only the introduction, principles of sealing, and the overall biophysics of the electricity. So any kind of surgery, the most important is we remove, replace, repair, or recognize what actually the reorganize whatever we have restricted out or to manage the system. All this has to be a balance of cutting and hemostasis. Then only we'll have a proper end result will be better. So if you are going for a better cutting mode, the higher the cutting is, you have a lower hemostasis. But if you look at more hemostasis, the cutting speed reduces down. So we need to have a balance between both to give best results in the surgery. Going forward, we'll have a couple of questions. This is one of the most important questions. We use electricity in daily procedures, but why don't patients get electrocuted during the surgery, or the surgeon doesn't get electrocuted during the surgery? We're using the same energy source for lighting a bulb. Similarly, which waveform is safer when you're using a monopolar or the quaternary machine, which we call generally? Is it a cutting waveform or a coagulation waveform? Why is lateral thermal damage is important? And we always talk about lateral thermal spread, what is actually lateral thermal damage and all. So what actually is lateral thermal spread and how it works, and what is the problem with it, how it actually happens, and how does our energy modality produce it when you're using it during the surgery? So in our surgeons, overall, every surgeons, if we talk about, nobody has actually, we have chapter as a biophysics in the system basically, but there is no, this is just a survey which is done in USA. It has shown that more than 50% people they don't have actually a formal training on energy-based instrumentations. And when normal questionnaires were actually passed on to them, they were not able to answer even 55% of the questions. So that is what that is why this training is important, because this can lead to more adverse events than regular surgery, which can lead to patient outcomes, which can affect the patient outcomes overall. So we'll see in the coming slides how this patient outcomes can adversely gets affected, or it can increase the cost of the cost of surgery or the cure for the patient in case of this improper use of the energy sources. Our common goal currently, whether it is Ethicon or as a surgeon, we look at as the optimal patient outcomes. So what we do is we work on to improve the interaction between the tissue and the device, whichever device we use. Factors which has to be considered is definitely human. So when I say human, the patient, what is his current situation, his comorbid conditions and other disease status, the technology what you are using, then the surgeon what actually how trained he is to use energy modalities basically. Procedure wise, there is never doubt with the surgeons ki, okay, this is what the issue is, but it is always when using energy sources, which is best ideal modalities or which is the best way to use it basically. Fundamental just a principles basically which is everybody follows basically when it comes to the surgery. Asepsis, tissue compression, tissue tension to reduce as much as tissue tension. Tissue dynamics is always considered whether it is hydrophobic in nature, hydrophilic in nature, or biphasic in nature. It is more of vessels or only the thicker tissues like stomach or bowels. Minimal tissue injuries, tissue repair, hemostasis. These are the major point of considerations when want to manage the surgery basically to for a better outcome. Principles of hemostasis, there is a coagulation cascade. So as you know, there are different factors when it comes to a coagulation. There are total 14 factors which affects the overall coagulation of any site of the body. So what it takes time is like in minutes basically when you talk about is vasoconstriction, platelet additions, platelet aggregation, platelet or hemostatic plug formation. Then it takes hours for to form a fiber clot retract and recanalization. It takes some days for recanalizations. So our major during the surgery, the major work starts in minutes and hours, because this is the place where actually the patient outcome is decided. So to have a proper to augment hemostasis or to help in better hemostasis, we have three components which is generally used. One is mechanical energy, which is tissue compression, where you use staplers or sutures for providing that electrical for mechanical hemostasis. We have topical hemostatic agents like your Surgicel and other hemostatic agents which are used for augmenting the hemostasis. And thirdly is the energy modalities. We have different energy modalities which is like monopolar, bipolars. Then we have harmonic, laser as well in the system comes to augmenting hemostasis. So this question I bounce it to all the participants here. What are the major characteristics you look into an energy source? So just I don't want any specific this thing. You can just type in your comments into the chat box so that I can just have a look. What is the ideal source which you are looking at? What is the ideal energy device which you want? It is like more of ergonomic, or you want a cost-effective one, easy to use, precise, reliable coagulation. So based on that, I can during this presentation you'll be able to understand which is the best energy device which you are looking at. So I would request participants if they can provide input into that basically. Precise. Dr. Salil Agarwal has said precise is most important basically. I understand for finer dissections you're looking at preciseness of the device. Good ergonomic. Reliable sealing. Of course, sealing is very much important. Minimal tissue injuries. So looking at the answer, ideas which Sajan is looking at currently is, what I understand is more concern is safety for the patient. Because you are looking at reliable coagulation with primary aim, minimal tissue injury, again reliable sealing. So this all are basically for so that you have a better result. Okay, ergonomic, precise. This is all are major important things which you are looking at. Tissue injuries, again you want safety, reliable safety. Sealing, again you want a good sealing. Safety may or may not be compromised. Good ergonomics for user friendly maybe. No other side effects. Okay, no thermal side effects and other things. Okay. So what we talk about is there is principles of sealing actually implies onto basically two factors. One is the physical factors and another is biological factors. When we say biological factors, there are three major factors which works onto which helps in giving us better sealing or hemostasis. One is collagen elastin ratio in the tissue. So more of collagen is there in the body, there will be better hemostasis. More elastin, it will have a poor hemostasis. Just like well known to the surgeons. So I'm not going to put any effects or any ideas onto that. I'll be working more commonly onto physical factors, which is compression, heat, and time. So to make it very simple, we'll call it as HTC: heat, time, compression. So energy device can improve hemostasis by heat, compression, and time. So time is basically length of time. Heat means application of heat, how much you are giving the heat. It is 100 degrees Celsius, 200, 300 degrees Celsius. Use of compression. Compression has been one of the best thing in the market or best thing in since our age-old Ayurvedas, everything has been said, like heat and compression has been the most important factor. Even in the Hollywood movies or Bollywood movies, you see anybody bleeding, they ask us to put a compression there, apply pressure. So compression has always kept as a most important thing. Heat and then followed by time. The length of time, more time you have to keep it for a more bigger bleeders. Compression is depends on to pressure applied, uniformity of the tissue, viscoelasticity of the tissue. So within the tissue, different types of tissues, if it is a radiated tissue, inflamed tissue, or of calcified tissue, the difference of compression will be different. So suppose it is a fibrotic tissue, you cannot apply more pressure onto it. You have to keep a light pressure onto. If tissue is not uniform, it is bleeding from abrupt pressure, abrupt location, then we have to put more gauze pieces or more sponges to keep a compression onto it. So collagen elastin ratio, which we were talking about, was here like more collagen is most abundant in the body. So if collagen is there, we'll have a better, we'll have faster hemostasis and faster coagulations. But elastin actually reduces the possibilities of your for the sealing. So elastin ratios are very high in aorta and in even the skin. So this is what actually, when we apply a vessel sealing in collagen, this is what actually happens. With only elastin, this is what happens, and it opens up again. So sealing any tissue which has more elastin ratios will always have an issue because of it has a property of coming back to its original position, which is called as tissue hysteresis. So vessels with collagen and elastin put together, this is how actually it looks when you're ligating a vessel. Vessel properties also makes a big difference when it comes to the sealing capacities. Patients with hypertension or have a vessel size depends on to the which is the vessel size. Like for example, you are going for pulmonary artery, pulmonary veins, or IMA, SMA. The size of the diameter of the vessels makes a big difference. Water content also makes a huge difference in the viscoelasticity of the tissue. So it affects the overall sealing capacity of it. So this is energy truths basically when it comes to the all instruments get hot and are greater than 60 degrees activation. Temperatures in tissue must exceed 60 degrees Celsius to coagulate. Temperatures above 60 degrees will cause a irreversible damage. These are the facts basically which is true about it. Any temperature which goes anytime during the tissue when you're using energy sources, temperature going beyond 60 degrees, it is irreversible damage basically which we do to the tissue basically. So if you see here, this is a small comparison of the chart. Till 60 degree, there is a reversible tissue temperature, tissue damage if you are applying a temperature up to 60 degree. 60 to 100, we have more of collagen denaturization. It is irreversible tissue damage. It starts after 60 degrees Celsius. And post 100, it is desiccation. And above 150 degrees Celsius, it's purely only char, nothing else. It's a carbonization. So principles of tissue healing when it comes to tissue heating is we have total currently which is mostly used three things: electrocautery, electrosurgery, and ultrasonic. When I say electrocautery, it is not the regular monopolar pencils which you are using. You heat up the device using electricity, and the heated device is used on the patient to coagulate the bleeders basically. So that is called as electrocautery. So in general terms, we do say electrocautery for all our electrosurgery units. So we should say only electrosurgery, or we should say a monopolar or bipolar device. Because electrocautery as such in physics term is heating a metal and then that heated metal using it for coagulation. That is called as electrocautery. Electrosurgery is the monopolar bipolars which we use. So this is direct. Then we have ultrasonic, where heat is transferred to the tissue through ultrasonic waves and friction caused by the blade basically. So it's more of mechanical. Here in case of electrosurgical, it is active energy which is given to the tissue directly in electrosurgery, which is in either case of monopolar or bipolar. Tissue damage is very important because it is it helps in faster healing basically. If there is no lateral thermal spread or no lateral tissue damage, it will improve the patient outcome automatically because there will be no pain, no adjacent injuries will be there. It will always give a better dissection and separates the tissue planes better. So what actually affects is definitely water content affects the type of tissue. It has more collagen or elastin. Time on the tissue, what is the peak temperature, what you are using, it is 60 degree, 100 degree or beyond that, and type of energy which you are using. All these 5 factors affect the overall lateral thermal damage. So coming to both these factors, when we are uncontrollable is biological factors definitely. So these factors which we can control it, this automatically helps in better sealing and hemostasis, but it will give us a faster heating and repair with lesser thermal damage and lesser inflammation. Principle of electricity, when we talk about any electricity modality, it always takes the least resistant path. It always seeks a ground and it requires a circuit to be completed. So when it starts its circuit, it should start from plus, it and should to minus, basically anode cathode, which we talk about. We read somewhere in 10th standard, I guess. So this continues. This is what is the DC, direct current. So it starts from the battery and ends up in the battery, and it keeps on revolving around. In case of alternate current, it keeps on changing the path. It will be positive, negative, negative to positive. That is why it is called as alternating current, because it keeps on changing the direction. In case of direct current, it is unidirectional. So we are using actually alternating current in all our devices. Why patients don't get electrocuted? Here we have the answer here. So our muscles and nerves have a stimulation process till 100 kilohertz of electricity which we receive. Anything beyond 100 kilohertz, we don't have any kind of neuromuscular stimulation. So that's why the radios which we use, TV or the electrosurgical units what we are using, that works more than 100 kilohertz, 200 kilohertz, and the 500 kilohertz are further on. So it doesn't, we don't get electrocuted, or patient don't get electrocuted when we are using an electrosurgery unit. This is very important aspect of physics basically. So V is, there's nothing but it is a voltage. I is basically your current, R resistance. So why this picture plays very important role is, we spoke about current takes always a least resistance path. So V, if you talk about as a driving force, as a car, if you are driving a car, the current is basically the amount of current flowing. So this is a power of the accelerator what you are putting into it, and resistance is the obstacle. So you come into obstacles, you will increase your accelerator, so you're giving more power to it, more current will be given, voltage will also increase, because of which they are directly proportional. So in case of downhill, it will go ulta, because resistance is low, so your current and the volt both will reduce down. Hope this is clear, because this is most important aspect coming forward now. Any questions? If we have any questions, we can go ahead with it. Otherwise, we can start with the second session basically.
You said that the 20 degrees Celsius, so that is the amount of heat generated at the instrument, or it is the amount of heat transferred to the tissue?
So this is with respect to 20 degrees Celsius, you said, sir, with respect to?
60 degree temperature, you said. That is amount of heat which is generated at the instrument, or the amount of heat which is transferred to the tissue?
The amount of heat transferred to the tissue, sir. So like when you're using an electrocautery machine, or you're using a monopolar pencil or a harmonic, and you're touching to the tissue, the temperature when it rises within the pencil and which is passed on to the tissue, the temperature, if it is 60 degrees Celsius or above, it becomes as irreversible. The damage is irreversible after that.
Okay, as per your requirement, it should be less than 60. That's what?
Sir, you cannot do it at less than 60, sir, because what happens is, for a better coagulation, you require above 60 degrees Celsius.
So minimum it should be 60. That's what you mean?
Minimum should be 60. That again depends on to the condition of the tissue, sir.
And what are the measures taken on the patient or on the table to make the circuit complete? So, and any effect on the patient can be avoided.
Sir, that we have a coming presentation now on monopolar, sir. So we'll have that, sir. Dr. Prem has asked, amount of time applied is directly proportional to increase in temperature, or temperature remains same irrespective of time. It again depends on to the energy source what you are using. So based on the energy source, if you are using it for more time, there is a high temperature which is increases. So if you remember the concept of HTC, heat, temperature, and compression. So all three affects the overall coagulation. So if you increase one aspect like suppose you increase only the heat, so you have to increase the temperature. So for the temperature, when you increase the heat, will also automatically increase. So both will cause a thermal, more lateral thermal spread, or more energy to the patient basically. I hope I hope you answered your question. Temperature will always increase with respect to the time you use. So if you are using for more number of time, it will increase. So this will be talking mainly onto the monopolar technologies, the electrosurgery units basically. What is the principle involved in is, so we spoke about in the last presentation is like it follows always the path of least resistance. and there is a current or the power which is keeps on continuing going to it. Again, secondly thing is injury is proportional to the current concentration. The more current is given, injury onto the tissue or the damage to the tissue is more. So this is what we are talking about cautery. So if you are heating a metal just like that with the help of any source of heating material other than electricity, it is called as cautery. Electrocautery is you are heating the metal with the use of electricity, then using the same thing to coagulate or help in dissection in case of patients, which is used in earlier days. If I am not wrong, during World War I, it was used mainly. Then the current situation which we use is electrosurgery, where we use the alternating current which actually passes through the patient. In previous two cases, there is no electricity to or through the patient. In case of electrosurgery, which is the latest modality which we use in day in and out, is this thing. So this is how the overall circuit looks. Sir was talking about the circuit, what actually it should be look about. So this is what the current flow it should be looking at. So we have the power plug here. We have the box, which is the electrosurgical unit or the monopolar bipolar machine. This is what the monopolar pencil which is surgeon is using onto the patient. We have a written pad, and the patient is part of the circuit. So surgeon will be using it current here. This current will go through the patient, enter to the written pad, and come back to the machine, and again grounded. So during this situation, if there is another option for the grounding of the patient, for the grounding of the current may find some other way. Suppose it may come from here, it may ground like this. So this is all called as alternating sites where currents can flow. In further coming up slides, I'll share you how we can avoid all these issues as well. So we spoke about electricity like it passes through the least resistance path. So it is just like if you see a crowd of cows which is going or passing through a road, if you see a car standing in front of those cows, this herd will automatically move their way towards the side of it, and it starts walking around. So this is one of the simple example like how the electricity passes. Electricity also passes the same way. It finds a resistance, it will pass from the side of the resistance. So here picture itself, you can see this. If there is a resistance, resistance could be of anything. So suppose you are applying electricity and there is no water content left over in this portion. The electricity will start finding the alternate path which has least resistance. So cutting and coagulation waveforms which is there available in the market now, all are. We have pure cut form. This is a wavelength which we are talking about. Wavelength is there is a current which is flowing directly, continuously to the patient. Then we have blend 1, blend 2, blend 3, and coag mode. So in the blend 1, 2, 3, there is spike of currents and little bit of gaps. But when it comes to the pure coag mode, there is a spike of current, but they have a gap between the two waves. Please keep this in mind because this works. What it shows is the current is on for a longer period in case of pure cut mode or the other modes. In case of coagulation mode, it is on only for 6% time and 94% it is off. So this gap, what it shows during the two waves, the current, there is no current which is passing through the patient. So there is less current which is passing through the patient. This is one very important thing which I would like to would request everybody to have a look. So if you see here, cut form and wave form, what is the difference you'll see here now. So this is cut form. You can see the tube light is actually igniting continuously. In case of waveform, it ignites. There is no changes actually. In cut form, there is keep on blinking. You can see there is keep on blinking. In case of waveform, it is Sorry, in case of coagulation form, it is once time only it is getting. So there is less heat produced because of this. So we are using a monopolar cut form here in onto the lever basically. It's a porcine model basically of lever. This is we are using a cut form. So if you see here, this was used for 1 second, 2 seconds, 5 seconds. Then the third one, what you're seeing is basically 10 seconds. Now this is waveform. Oh, sorry, coagulation mode. So sorry, ulta. So if you see here, in either case of coagulation and cut mode, the current which is passed is more. So if you see here, the first line which you are seeing, it is a coagulation mode, and second line which you are seeing is a cut mode. 5 second, 1 second, 2 second, 5 second, and 10 second of activation. Dr. Prem's question was saying that temperature increase is there or not when you're using for more longer time. So if you see here, whether it is cut mode or a coagulate mode, whatever temperature time you are using, there is a high current concentration and there is high temperature or high temperature, which is leading to a more tissue damage. So if you see in the same current mode or same watt mode, the coagulation mode gives you more damage than a cut mode. Cut mode has a lesser damage to the tissue compared to coagulation mode. So it is said like cut mode is more safer than coagulation mode. This is another beautiful video which shows basically like how deep is a cut mode or a coagulation mode when you are using it onto the tissue. The lateral thermal spread, which we talk about basically. So if you see, cut mode doesn't give you much deeper cut basically compared to coagulation mode. So the lateral thermal spread in case of coagulation mode is more compared to cut mode. The additional tissue effects, this is what we generally use basically. Desiccation, where we apply low current, high voltage for better coagulation. Then fulguration or the spray painting, what we call it in the cautery, when we generally use it in case of lab coolies and all, where we just use a spray for lever bed. Vaporizations, when just to give a rapid hit so that tissue cells water evaporates in that basically. This helps in faster cutting mode basically. The safer, so even the videos which we saw, it shows very clearly that the cut waveform is more safer when you're using it as an electrosurgical unit. So it has less spark travel, lower temperature, but it is good to use basically because it is more safer form. So tissue damage is proportional to the power applied to the area of contact. Current concentration is very important in the surgery. So this is one thing which you can just have a look onto the video. Please observe it very nicely, because if you see, current is actually being passed on to the sausage in the top, but there is effect in the joint what you are seeing here. I'll play the video again. So what actually happened here is we were giving electricity to a particular location where we wanted to give. Basically, we are intended to use it in sausage, but the joint actually had the least concentration because the surface area between the joints of two sausage was less, which where the concentration of the current increased. So in case of cautery pads, when we are using, so when you are using a sticky pad which is applied onto the patient, so that is a small concentrated area. So if there is any change in that, or there is a reduction in the space there, so there is high chances of cautery pad burns basically there. Apart from that, during the surgery, when you are using it, this is one unintended condition what actually happens in case of surgeries. So this is what happens is the current concentration. We will be applying current here, but the effect will go to duodenum or the any small ball which is there in the system. So that is why it is very important that when we are using current, it should use as safer current form as much we can use. So cut basically is basically considered more when you're using. So these additions can affect to the duodenum, which may lead to later on to a duodenal perforation or a bowel injury, which can lead to any other issues. To avoid this, only one thing which is advised is to use a safer current form. Using cut mode in cases of you have any doubts where actually you think there will be a current concentration which may affect the other organs, especially in cases of heavy additions. So this is a comparison study basically with respect to pencils and needles. How the water concentration actually works, or there is a difference in the water concentration. So this is a regular pencil which is used with a needle. So if you see the video here, what is happening is I hope video is visible. Okay. The first one what he used was basically your regular pencil. Second one what you are seeing now here is actually a pencil. So pencil has a needle. So needle, what has happened? It has increased your current concentration actually with the needle. So because of which it is giving you more watts, more concentration onto the tissue, because of which you are finding high effect onto the tissue basically. So with the instruments also you can change the current concentration. So for monopolars, this is two important aspects. Any monopolar device will give you a very good reliable sealing or for vessels up to 1 mm basically. And we can increase that basically with the compression as well. Potential risk in monopolar electrosurgery is basically the return electrode failure. The electrocautery pads which we use it onto the patients, that is one thing which is a major issue. Then we have direct coupling, capacitive coupling, and insulation failures of the device which you say, and a surgical fire. This is question from sir. Basically, Liga clip or Hemolog when we are using in case and we are using electricity, generally this titanium alloys or titanium are inert materials. So there is no current which actually which will cause any kind of effect with this tissue. But in case of Hemologs, it may affect because Hemologs are plastic in nature and they react onto the heat basically. So this is what we show. I showed you basically with respect to the current flow. So return electrode energy, which is the cautery pad. So this is what the position is. Originally, it should be like this. If there is a changes in any kind of patient pad electrode difference, there is high possibilities of cautery pad burn at the site of pad. This is what is called as return electrode pad injuries or cautery pad burns, basically. There is one more thing which actually increases the chances of return pad electrode burn is, suppose the pad we are placed in the buttock, but we are operating at thyroid, that is next. So the distance travel for the vessels, distance travel for the current flow will be from neck to the buttock, which is a big distance. So during this travel, current can flow from any part of the body. So it is advisable the pad should be as close to the surgical side as much as it can. So in case you are doing a thyroid or a breast case, it should be in the back of the patient. If you keep it in thigh or the buttock, there is high chances that current may find an alternate way to move. As it is mentioned in physics, alternating current, it can go through a place which is least resistance. So during this flow from here to here, if it finds that there is some other place where we can go down, it will go. So this is one live example of how a pad side burns happens basically. So this is how actually it looks, cautery pad burn which happens basically. When there is improper CAD connect with the pads, the burn will be like this only. So patient will have a pad burn exactly here. So all electron pads have the same thing. Only thing is issue with the sticky pads, because it has a gum which generally goes off after certain use. So it is avoided not to use it second time basically. We also have a different pad which is called as a mega soft pad, which is which works on capacitance. This pads actually works on the resistance which is calculated. So in case of mega soft, which is our new brand, which is a return electrode pad, it reduces the chances, or it gives no chance of pad side burns, because there is no heat buildup or there is no current which is supposed to. We give a big length of a pad which will help you out to cater the disease, which any place you do the operation or the surgery, current can flow from any part. So it is a conductive mesh which is there in the between with the insulating gel on the two sides, which helps in passing on the current to the from machine to the through the patient to the machine back. This is a very important question for everybody. How many times everybody has got a glove burn? I think most of the people have got a glove burn actually during the surgery. So this is what we do generally commonly when we are doing a surgery. Operating surgeon will apply artery forceps, and they'll ask the assisting surgeon to burn it. So during this situation, what happens is most of the times we have seen the surgeons, they get a glove burn. So the reason behind is when we are doing this, just a second. This is also called as direct coupling. So when we are doing this, there are two factors which has to be kept in mind. First is holding the instrument with a full coverage, or we holding the tissue properly. For example, like suppose this is your artery or forceps. If you're holding like this, you'll give a more current concentration on your fingertips. So it should be holded properly like this. So you give a more surface area, whichever instrument you're using, whether it is artery or whether it is forceps. So you should give a full coverage to the instrument. Secondly, when your assisting surgeon is actually applying the electricity to you, he should not activate the cautery pencil in the air. If he activates in the air and brings near to your hand or near to the instrument, it is going to cause a glove burn. So what happens is, when you are activating in the air, because there is a resistance in the air, there is a lot of current which is actually built up in the pencil tip. So when you try to reach to the pencil, to the artery or the forceps, the current goes as a bulk. So because of which you feel a shock or a burn sensation in the gloves, and gloves get burned basically. So this is what is the example of a direct coupling. So this is actually a direct coupling which we are talking about, and this is unintended direct coupling. So if you see here, so if you see here in this video, it showed very clearly that you intended to use it only to apply current onto the surface of the staple line, so that you avoid the bleeders what you are seeing, but it is affecting to the staple line directly. This is one important video. Basically, I'll just show this one. This is called as a indirect coupling. So by mistake or during the procedure, what happens is, the monopolar pencils generally, there's just a big length of pencils. So we generally keep it rolled over some tissue or some arteries or forceps somewhere. So if there is you're applying electricity current somewhere else, this can also cause us indirect coupling current, which can affect the overall patient basically. So this is what actually indirect coupling can do. You can see just with we are not keeping directly into the current, but still it is causing a tube light to blow basically. So the current there is a current always flowing through the wires, which can cause an electromagnetic effect, because of which you can see tube light is getting on. These all are examples of capacitive coupling, where we connect with the trocars, or with the trocars also indirect coupling or direct coupling happens, capacitance coupling. With the metal trocar, you can see here actually. So we are trying to coagulate directly from this end actually. But if you see, if you trocar sleeve, if it is kept near to the tissue, your intended usage will be there in the end of the distal end of the trocar, so distal end of the instrument, but it will cause an unintended spark in the trocar edges as well. This is what is called as capacitance coupling. Even the instruments, if there is a defect, generally whatever cautery pencils, the monopolar hooks and other things which we use during the surgery, if there is, they are generally insulated. But when we are reusing it, if there is a slight issue with the insulation, we can see there will be a spark which can come up from any portion of the device basically. So that insulation has to be maintained. So always we should avoid any kind of current implant or something like that to happen with the manufacturing defect basically. So this is what actually is a study which was published in surgical surgeon edition, basically published by Yardley and Donaldson, that there are actually more than 650 surgical fires which happens per year, where 70% surgical fires are actually caused due to electrosurgical equipment ignition. So this could be because of multiple reasons, could be of capacitive coupling, or because of the direct current or indirect current or surgical site surgical site or pad site burns basically. So safe use of monopolar electrosurgery recommended practices to consider using maximum times to use cut waveforms. This is a more safer form. Using a lower power levels for a desired tissue effect is very important. So as low as you can to increase the better tissue effect. Insulation should be checked regularly for the instruments which are using with the connectors, tokars, other things as well. Use isolated generator and patient contact quality monitoring system. Why it is said as isolated generator and patient contact is because every electrosurgical unit is the box actually affects most heavy electromagnetic waves. So if it is kept near to any other instrument, like suppose near to harmonic or near to the anesthesia machines, it will show you abrupt readings, or it can affect the overall performance of the device. So all ESC should be kept separately, isolated, and minimum 1 to 2 feet of distance should be kept between the instruments, between the machines basically. If you have any questions, we'll go ahead with the questions, and we can go to the next session basically. So can we go ahead?
Yeah, you can please go ahead.
So we had already spoken about monopolar already. I'll just take up through bipolar in a quick way, because what happens, monopolar, the patient is the part of the circuit and there is a current which is flowing through the patient, from the machine through the patient to the machine. But in case of bipolar, the current is actually within the segment of a tissue wherever we are applying. So it is basically, there are two types of energy sources which is available in the market. So which we call it as traditional bipolars, which has normal jaws and you just clamp it and you do the coagulation. But there is advanced bipolars which gives you a stronger sealing capabilities, and heat, temperature and compression is totally different when here comes to. Here the compression is, in case of monopolars, we had only heat and time. We didn't have any compression when you're using a monopolar device. In case of bipolar device, we get an additional component of compression, because of which heat is increased and time is reduced, because we got a compression as an added benefit. So coming to the traditional bipolars, so that is your traditional bipolar unit. This is traditional monopolar unit. In bipolars, we don't require a cautery pads. So only at the site of the surgery will have the current concentration. We have high current concentration, definitely in case of bipolars. We have some kind of tissue compression. We will not say we have a very good tissue compression, but we have some type of tissue concentration. current can be controlled by the surgeons, because you see, keep on do the observation basically, because the kind of current concentration what you want, or the kind of compression and kind of coagulation you want, you will keep an eye onto it. So it is more of a surgeon controlled energy delivery. This is the only concern with this is a ballooning effect. So as you know, there is a current always passes through a least resistance path. Here also it works out the same way. If you observe this video, you can see that your intended use was only at the jaws, but there is a ballooning effect which is happening, and because of which there is a huge current which is passed on to the sides of it. This is one of the picture which says very clearly your intended current flow was between these two jaws at this place within the jaws, but current has passed on once the water levels in this or conductive material between the tissue has reduced down. So current has started finding its own way, and it has formed a balloon cascading along the jaws, because of which you will find there is a sideways ballooning in the tissue as well. Traditional bipolars, the major concern is you don't have enough compression here. So the best way to do an anastomosis is intima to intima compression is very much required, where which gives you a better compression. In case of this, we don't have that intima to intima compression in case of traditional bipolars, because compression is minimal. It is not having a good compression compared to traditional bipolars or any other devices. As rightly said earlier, we had said like monopolars are recommended to use it up to 1 mm vessels for coagulations. In case of traditional bipolars, 1 to 3 mm of diameters are considered safer and good for coagulations. Coming to the advanced energy sources, the plus point of advanced energy sources, it has a different mechanism altogether, which actually has a different algorithms which helps in managing the tissue temperature, managing the blade temperature, jaws temperature, and managing the overall current profiling. Apart from that, this gives you additional benefit of cutting as well. Whereas in many places, you will find other bipolars which you are using, it doesn't have any kind of cutting effect. So we have different types of cutting and coagulation mechanism in this. So mechanization of compression, there are different types of mechanism of compression. There is a spring and pin configuration, where there is, you can see the jaws type, then tube within a tube. This is what we see within the tube. This is spring and pin mechanism, which is basically just like a crocodile mouth. Then we have an eye blade compression. So eye blade compression is basically from Ethicon. Coagulation process, it is critical for sealing, because of coagulation process is nothing but when we apply heat, the protein which is there in the tissues, it get denatured, which forms actually a sticky coagulant, and because of which it coagulates the vessels. So in advanced bipolars, what it does, it actually coagulates with moderating the temperature within 100 degrees Celsius, especially with NSEAL, Ethicon's platform, basically NSEAL. It generates heat enough, that is 100 degrees Celsius, to denature the protein, and because of which it actually keeps on modulating the current and not allowing the current to move out. Because in case of monopolars, in case of bipolars, we have only two cathodes, positive and negative. In case of NSEAL, we have multiple options for anodes and cathodes, positives and negative sides are multiple options we have given. So eye blade, we have a different blade setups here. So it has 6 ways or 6 pathways through which it can pass the current. So in NSEAL, the current flow is, or the ballooning effect which you see in regular bipolars, is not there in case of NSEAL. Another thing is how you approach the vessels. A perpendicular approach is considered the safest and the best way to ligate a vessel. If you see in the picture itself, it shows when you do a 90-degree approach, a 5 mm vessel will be a 5 mm vessel. But if there is a 45-degree or any other angle approach, the same 5 mm vessel diameter may increase to 7 mm vessels. So this angle approach will give you a better, when you approach perpendicular, that is 90 at a 90-degree approach, you'll have a better sealing at the edges, because if you see the leakage or the vessel sealing failure happens only in the edges of the vessels. So that's why perpendicular approach is always considered best for the vessel sealing. Again, in advance, this is what we spoke about bipolars, traditional bipolars where the intima to intima is not there because of the compression. But in case of advanced bipolar, we have a better tissue sealing because of vessel sealing because of intima to intima compression. So here we have more compression. Heat is still higher, till 100 degree and above. Length of time is comparatively less because we have more compression now. Application of heat is increased and length of time is reduced. So what actually happens is, in case of advanced bipolars, we have both. In case of advanced bipolars, if you have any kind of doubts, please, bipolars or monobipolars or bipolars, if you have any kind of queries, we can pick up now. Then we'll move on to the final session of science of energy, basically.
Harish,
Yes, sir.
Whenever we put a clips, no, like a cystic duct or cystic artery.
Yes, sir.
In between, is it advisable to cut with a cautery or a scissor?
Sir, it is advised to use a cold cut instead of using any energy source when there is a metal clip or a hemolog clip in the site where you want to cut the thing. Because what happens is, you never know, so there is a current which may pass on to the adjacent metal, or the way we had shown one video where actually they are trying to coagulate the staple line bleeder, but it is affecting the staple line. So that can lead to other issues. So it is better advised to give sessions basically like to avoid more of cold cut rather than using any other energy source in these cases.
And what about this metals patients wearing some of the things in the toes?
Like, okay. So what happens, sir, like this metal rings or the earrings, or sometimes many patients complain of saying that I am Mangal Sutra, they will not allow you to remove. So what happens is, this all are potentials or alternate site of returns or for earthing of the circuit basically. So there are high possibilities because these are smaller in size. The way you saw in the sausage video, the chances of current concentration is high in these positions, in these metals. So patient may get a burn there. So because it is works on resistance path only. So there they'll find a least resistance because current concentration will be more. So they'll try to go out from there and there will be chances of burn. So it is advisable to remove as whatever it can be removed from it, or else you can use a mega soft, which actually is safer to use even with the patients with implants, pacemakers, or even with the products like pacemakers, implants, and even if patient want to keep on wearing the nose ring, earrings, or any other ring they want to continue, even with Mangalsutra, they can keep it on. You can use it, and it doesn't require any patient preparation also, sir. Mega soft, because generally when you're using a cautery pad, you have to shave off the area where you want to apply the pad. In cases of pediatric cases, it becomes more complicated to apply. In patients who has specially burnt cases where you have to operate the patient, you will not find a proper site to apply the pads. So these are high risk of going for alternative alternative side burn basically. This can be avoided by using Mega Soft, sir.
Thank you. Thank you.
There was one more question, I think. So regular bipolars, if you say traditional bipolars, you can use it up to 3 mm vessels, sir. And but up to 7 mm vessels, the new bipolars, the advanced bipolars like NCL, Medtronic has LigaSure. This can be used up to 7 mm vessels really. So we'll come to the last session of the presentation. Basically, I'll not take much time here. It mainly talks about ultrasonic energy sources, which is our harmonic. So harmonic has been there in the system from long time. So plus point of this is it has high compression, it has good heat, and time taken is also considerably same. So how does the energy system has evolved during this overall era of harmonic? Basically, first time the harmonic came was in the year 1988, and after that it has been evolving. We had ultrasonic laparoscopic devices with the 10 mm shears. Then we came up with 5 mm shears. Now whatever you see today is all advanced shears which you see in the current scenario. So we devised a adaptive tissue technology in the harmonic so that all shears whatever you use are used in this. Another thing is if anybody want to see oldest harmonic in the country, so you can see it in Belgavi actually. The oldest generator available is with what is his name? I forgot. It is available in Belgavi itself. I'll message you where you guys can see this the oldest generator, which is in working condition till date. So Harmonic is like a trustworthy brand which you can see in across the globe. So what was actually traditional ultrasonic energy? So what was traditional ultrasonic energy was current was passing through a transducer, basically, which is a basic transducer, which actually converts the electricity energy into ultrasonic waves. What green color you are seeing is ultrasonic waves. So once the ultrasonic waves are converted, it causes the blade to form a movement. So this movement is in a to and fro motion. The same way when you are trying to cut an apple, the same to and fro motion will be there in this blade. The only difference is this blade movement will be 55,500 cycles per second. So what actually it happens is there are piezoelectric ceramics in the transducer. This actually vibrates at a very high frequency, because of which there is a ultrasound waves which is formed, and there is a which helps in movement of blade. So this is how actually the movement happens. So what you are seeing in the screen now is compression and relaxation of the metal. So harmonic blade, what you see, I hope my video is visible. So the harmonic blade, what you see here is like this. Okay, this is the blade. So when you activate the energy, we see it in the naked eyes. The blade is moving like this, up and down, to and fro. But actually, it is not moving to and fro. The blade is actually contracting and expanding, contracting and expanding. So that is why the technology is totally different than any other device. So this is what the expansion and contraction is happening in the device. The blade is actually contracting and expanding, because of which you feel there is a to and fro motion of the blade, and that actually causes the movement of the blade. So how does harmonic actually does a coagulation? So first is the coaptation, which actually helps in coagulation. So first is coaptation, the application of the two jaws of the harmonic. Then which helps. Then after the movement of the blade, which is moving at around 55,500 cycles per second, this actually generates a heat which actually breaks the hydrogen bonds in the protein that is denaturization, followed by sealing of the vessels, which is the same mechanism which is used by the bipolars as well. But difference in harmonic is it never crosses temperature above 100 degrees Celsius. And because of its movement of high friction movement which it causes, there is a heat which is developed at a lesser temperature. So even at a 60 degree, 70 degrees Celsius, you will have a good heat generated in case of, because of the blade, high frequency of the blade movement. Why harmonic is very good product basically is because it is having a multiple function. It is very easy, user friendly product. Okay. So there are 5 factors which actually comprises of overall effect of the product. First is power level. There are 2 power modes in this. One is called as minimum mode and maximum mode. In minimum mode, you can increase the power levels from 1 to 5. So 1 will give you more of coagulation, whereas 5 will give you more of cutting. So during a surgery, if you see, always harmonic is kept under 3 and 5. So 3 and 5, you give you a balance of cutting and coagulation. So 3 gives you a balance of cutting coagulation. 5 will give you more cutting speed. Suppose you are going through a avascular plane, so you can always use a maximum mode and you can go around with dissection. But when it comes to the vascular plane, you can again come down to minimum mode. Tissue tension again works into this, because tissue tension is more tissue tension you give to the harmonic while you're applying harmonic, there is high chances that there will be bleeding. So it should be relaxed. Tissue should be relaxed when you're applying. Blade pressure, when we say about you want a better coagulation, don't apply the blade full closure. Full closure means approximating the handle fully, squeezing the handle fully. You do a partial closure and then activate the blade, you'll have a better coagulation. If you close it fully, approximate it fully, it will cause you more of, for example, this device. So if you are trying to close the handle fully, so this will give you more compression. Because of more compression, you will have a faster cutting speed. But when you are using it for lesser compression, if you do a compression which is less, for example, little bit light compression, and you activate it, you will get a better coagulation. Blade sharpness, again, if blade is when you're using it, the sharpness of the blade automatically reduces down. So with the blade sharpness also it affects. Blade location wise it affects, because if you're using in the tip of the harmonic blade, you'll have a better cutting speed. If same thing you're using at the proximal end of the blade, you'll have a better coagulation with whatever power level it may be. So these all factors put together works onto harmonic. So you can use harmonic for back scoring, you can use it for otomy creation. So you keep in a you can use it for otomy creation, you can use it as a grasper, you can use it as a vessel sealer, you can use it as a regular coagulation device. Vessel sealer in the sense it can take up to 7 vessels also. Harmonic, the advanced harmonic scissors can be taken for this thing. Dissection, definitely it is very good for dissection. Tissue plane dissection, we can do it. There is something called as cavitational effect, which is there with harmonic. So this cavitational effect is it helps in forming a plane dissection. So you suppose there are different tissue layers in the plane. So when you activate with the open blade, the water vapors are formed within the tissue plane, and that helps in separating the tissue planes. Then you can go inside and you can activate it and go ahead with the presentation basically. So factors affecting this, we have already spoken. High blade levels, we already spoke about this. High power levels will give you increased cutting speed. Low power levels will give you more coagulation effect. So how does this works? You can see in this picture is basically, so blade movement will be lesser in case of lesser power level. So in case of proximal blade, why I said is like you'll have increased cutting speed in the end, basically because that is the anti node and node. So because of which the anti-node position will give you better cutting speed, because that is actually expanding that location. Coming to the advanced energy sources of harmonic, advanced energy harmonic. So with the same generator, what we have done is we have minimized the heat. Also, what we have done is we have made generator and the shears both very intelligent. So generator every time keeps on monitoring the tissue condition when we are applying energy. Sorry, this is called as adaptive tissue technology. So when we are applying energy to the system directly at the tissue level, system, shear, all continuously senses the tissue condition, and based on the tissue condition, energy delivery is optimized. So this not only improves your or facilitates your sealing, but also improves your thermal management. Because here it is moderating the power levels automatically based on the tissue condition. So it automatically helps in you managing the managing the thermal profile as well. So in sealing, it will be more secure. The regular or the traditional harmonics will give you sealing up to equal to and up to 5 mm vessels. And in case of advanced sealers, where we have up to 7 mm vessel sealers in harmonic, so they can take up to 7 mm vessels. Only thing you need to be very clear about it, it has a cycle to complete the vessel sealing. So if in between it is stopped, it may cause an issue. So for this, what you are seeing here is the complete cycle of vessel sealing when it comes to 7 mm harmonic shears. So it starts with a preheating phase, then followed by vessel sealing and transaction. So during preheating and transaction, the blade movement is very high at a power level of 5 or 4 based on the tissue condition. So because of which, if you're stopping in between and again applying the energy source, you will again start from preheating phase. So it is avoided. It is said to avoid any kind of stopping in between when you are using a 7 mm ligation system for harmonic shears. So here you can see this video. Basically, this will show very clearly how A7 plus or HD1000i is used in case of it. So if you see here, the power level is very high. We are getting a vessel sealing at an intermediate level. Then for transaction, when sealing is done, transaction, it automatically goes to high end. So in the harmonic, it will show you exactly in case of harmonic, it will give you a cycle completion tone as well. So what is the benefit? What you get with 7 mm sealing is you have a stronger seals, you have active heat management because it is monitoring the tissue condition based on that, monitoring the power levels. You have higher speed because of the same. Precision wise and multifunction wise, both remains the same. Advanced ultrasonics, cost wise, it will increase the cost. So with this, we are at the end of the session, sir. If any questions are there with respect to harmonic, bipolars, advanced bipolars, or any other energy source, we can take up the questions. In the initial, when we started this session, which everybody was asking about, like what actually you want. Dr. Salil Agarwal was talking about precise energy source with good ergonomics with Dr. Nikhil. Dr. Naveen was saying about reliable sealing, minimal tissue injury, reliable coagulation, and no other side effects, which was actually primary concern. So seeing this, all the aspects of the energy modalities, I would like to coin a question to which energy source you feel, or which energy source, whenever you are using, whatever energy source you are using, what would be the better one? Okay. Naren sir has asked separate mode for bigger vessels or separate hardware. Sir, it is with respect to harmonic, sir?
Yeah, with respect to harmonic.
Okay. So, Naren sir, actually, with respect to harmonic, we doesn't require a separate modes as such. The generator itself is a software-driven generator. So, the moment you connect the new versions of shears, it will automatically identify the shear, and based on that, it will start working. So you don't require a separate hardware. Only thing is, disposable you change for 7mm vessels, it will work for 7mm vessel. If you use a regular shear, it will work for 5mm vessels. I'll just show you this thing. Just hold on, sir.
टिबियल ट्रैक क्यों कट करते हाँ हाँ why no
harmonic is not indicated for any ducts basically. It can be used basically, but it is not recommended as a, if you say prescribing insert what we talk about, it is not inducted, it is not it is not suggested of or prescribed to cut any duct basically. But you can always use it for vessels up to 5mm vessels when you are using regular harmonic. But in case of like this device, this is what is HD1000i, which is the latest in the market basically. So if you see, compared to regular harmonic, where you used to have two switches, one was minimum and maximum. In this, there is no minimum maximum. There is two power levels. One is called as advanced hemostasis mode, which will give you straightforward 7mm vessel sealing capability. And second is for your regular dissection.
Harish, Dr. Gopte here.
Ah, sir.
No, it was an excellent presentation. The last one, what you showed, Harmonic 1000 HD.
Yes, sir.
It is your innovation.
It's Ethicon innovation only, sir. It's a product.
No. Listen, man. First,
yes, sir.
It is Harmonic 1000 HD. Means you are Harish Deshmukh, no?
No, sir. Not my innovation, sir. Not my.
Or something like that.
No, sir. Not like that, sir.
To be on the lighter side, I just said that. It was an excellent presentation. 2 hours, it was mesmerizing. Most of our PGs had joined, but some of them, I think because it is on YouTube, I think they will see it afterwards. It's a very good recording which has been done. And you really covered all the aspects, right? Basic from monopolar, bipolar, and the latest harmonic shears, everything was covered in this. And staples was also covered very good. And basics of surgical stapling was very well covered by you. I think it will go a long way. Most of the postgraduates should know the basics. No doubt in our teaching faculty or teaching curriculum, we have a topic on staplers and currents in surgery. But practically, what goes behind all this was very well explained by you, because you being a technical person and you are quite a senior person in this field now. So thank you very much. And from our side, our organizing committee, and from JNMC, me, Dr. Kazgar is there, Dr. Kausalgi, Dr. Amit, Vinod, all of you, we thank you for conducting this for 2 hours continuously.
I thank you a lot for providing me this opportunity where I can share my inputs basically. In case I was not able to fulfill what actually the requirement was, I'm really sorry for it, but I would look forward for hands-on in the hospital, because that is something which open up the eyes more better way, because in the videos, in the presentations, it looks very easy to talk about, but when you see it and you do it personally in hand, when it comes to staplers or to the harmonic, or even to the monopolar bipolars. It actually gives you the exact figure what is right, what is wrong.
Because what I felt was we have been doing these workshops in so many years, but the theoretical aspect what we cover, because everybody wants to go and fire a stapler and they want to see, but what goes behind it, it takes about 2.5 hours to know it. But when we conduct these type of workshops, we also bring it down to maybe 15 minutes or 20 minutes talk and 2 hours stapling hands-on procedure. But I think now once we do a hands-on procedure, the PGs and students will understand it better and they will be able to grasp it and use it in their day-to-day practice. One more last question from my side. Now, given a choice for you, imagine that you are a surgeon, there is no cost effectiveness or no problem. Which is the best current which you will use? For example, I'll give you a scenario. You are the best, you are a surgeon, you have to do a laparoscopic hemicolectomy.
Okay, sir.
What is the best current energy source you will use?
Sir, basically, if you are doing an hemicolectomy, the major concerns are here we have the two major vessels. Whether you're doing right or left hemicolectomy, both SMA and IMA are involved. So in either case, we have to ligate these vessels, which are major vessels. So I'll be going with a new advanced ultrasonic shears. If there is no cost constraint, which is HD1000i or ACE+7, with that I can, because it's a design of HD1000i is a Maryland shape jaw. So I will go with that HD1000i because it will help me to ligate these vessels as well. And dissection wise also I'll have a better edge over any other device. Thirdly, the plus point of as a standby, I will keep it a bipolar, just in case as a standby.
Very good. Yeah. Thank you very much. I think Dr. Gasgar wants to say something. Then we'll
Sir.
Harish, thank you. Thank you for your excellent oration from staples to the energy sources. Our PGs have benefited. On behalf of our department, our HOD sir and our college, we were very thankful to you and we will eager to see you for live demonstration in our venue. Thank you.
Thank you, sir. Thanks a lot, sir. Pleasure was mine, sir. But
thank you very much.
Only
thing is, one of our PG is asking, are you going to take us for the scene which is there behind you?
Sir, ja sakte, sir.
No.
We can go, sir. There is.
No. Should we have the workshop here? They are asking.
We can have it, sir. We can have it, sir.
Because of this COVID era, no. When they saw this beach, they said, "Sir, a question puch lo that should we have a live workshop on the beach?"
We can have, sir. There is no problem with that. Only thing it should not be any
no, just on the lighter side. Correct.
Luxury spot should not be there. We can do it, sir.
Harish, we will arrange it in Hyderabad only.
Yeah. Okay. Thank you very much.
Hyderabad. We'll arrange it in Hyderabad.
Hyderabad or Bangalore also we can do, sir. Now everywhere we can get a wave.
Yes. No
problem. And wave we can get it.
Yes.
Okay. Once again, thank you, Harish.
Thank you, sir. Thanks a lot. Thank you, sir.
I think with this we come to the end of the session, today's session and a CME. So I thank all the delegates and participants and the postgraduates, and a special thanks to Dr. Amit Amangi, Vinod Kargi, Dr. Ramesh Kozalgi, and Dr. Kasgar and all other faculties who have taken active part in this. So I think it was a good success and a new type of CME where online, this is the first time in JN Medical College we are having this because of the COVID thing. And hopefully all the postgraduates actively took part. And I thank all of you all for attending this CME. Thank you very much. And I thank Zydus also. Harish we thanked just now, but I think Harsh we should thank. Harsh, are you online?
Yes, sir. Sir, I am online, sir.
Yeah. Harsh also, we should thank him very much because
thank you so much for giving us the opportunity to associate with you, sir. And we are obliged, sir.
Yeah. And one more, there is one postgraduate who I would like to mention, Karthik. Okay, Kartikeya, come here, Kartikeya. You come on this. So he was the force behind all this. Come, let him come on the camera because he was the backbone. Come and sit here. So he has done most of the work from here. Behind the scenes, he was there. So I a big thank you to him. Okay. So I think all the postgraduates should clap for him. Even though he is in first year, I think now we have got one very good resource person here also. And I am really happy that, see, because this is mainly for the postgraduates. It may look very simple now, but when he goes in future or when he has to conduct these CMEs or conferences, it becomes very easy for them. Because this is one of the parts of the training which I think is necessary in this new era. No doubt everybody has got mobile phones, net tech, everybody is technically savvy, all these things. But actually, when it comes to doing it, I have seen him yesterday also. He was the person who used to switch on the screens, go from here to go from there. And Harish from there has done a good job. Harsh from there has done a good job. But somebody handling here, even though Amit and Vinod are quite expert on that, but they also required a backup. So I thank Kartikeya for him. And I think with this we conclude. If Amit wants to say something, let him have a few words and then we'll conclude the CM. Thank you very much.
I'd like to thank everyone associated with this, especially the speakers who took out their valuable time to share their knowledge with us. I would also thank the postgraduates who presented very nicely, who put in a lot of effort and presented in front of stalwarts of surgery. And I would like to thank our HOD sir for giving me this opportunity to conduct this CME. I would have a special thanks to Harsh, who has been with us for 2 days, and also the Zydus team for conducting this CME without any interruption. And last but not the least, our clerical staff, Raju, Basavaraj, and Prakash for providing this platform and helping us everywhere. And also the Dome department for giving us uninterrupted internet connectivity for conducting the CME stream without any interruptions. So I would like to thank one and all for this wonderful CME. Thank you. Harsh?
Once again, thank you so much, sir.
Yeah. We'll conclude this.
Okay, so shall I stop the meeting?
Yes.
Okay, thank
Thanks
you.
a lot, sir.
Thanks.
Thanks a lot, sir.
Thank you all.